Good morning, good afternoon, good evening, everyone. Thank you for joining the show wherever you are. Welcome to everyone joining from Australia, New Zealand, the UK, United States, Canada, India, everywhere around the world. Welcome to another intensivecarehotline.com and intensivecareathome.com YouTube live stream. My name is Patrick Hutzel and I'm the host of your show. And today we will be talking about one of the most critical questions families in intensive care ask me every single day. Why is ventilation weaning taking so long? And can my loved one be weaned off the ventilator at home? If you're new here, hit the subscribe button, click the like button, subscribe to my YouTube channel, and click the notification bell so you never miss life-saving ICU and intensive care at home insights. So today's session is split into two powerful parts. First 30 minutes is why ventilator weaning takes so long in hospitals and in ICU. And the second 30 minutes is how evidence-based home ventilation care can transform outcomes and quality of life with intensive care at home. Now, I also want to welcome our viewers on replay because we have quite a lot of viewers on replay. Please drop your comments in the chat pad so I know what questions you have, so I can create content around what you want. Also, what makes me qualified to talk about high-level intensive care and intensive care at home.com topics? A little bit about me. Again, my name is Patrick Hutzel. I am a critical care nurse by background, having worked in critical care nursing for over 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in intensive care. I have been consulting and advocating for families in intensive care since 2012 here at intensivecarehotline.com and also at intensivecareathome.com. And I can very confidently say that we have saved many lives with our consulting and advocacy and with our intensive care at home service, where we send critical care nurses into the home 24 hours a day to keep our clients at home predictably and permanently so that they can live at home and cut the cost of an ICU bed by 50%. I'm also the founder and managing director of Intensive Care at Home. We provide tailor-made solutions for long-term ventilated adults and children with tracheostomies at home, tailor-made solutions for long-term or for ventilated adults and children on BiPAP, CPAP, non-invasive ventilation, also for adults and children with tracheostomy without ventilation, home cough assist management, home ventilation weaning, which is what we want to talk about today, home TPN, home IV potassium, home IV magnesium, home IV fluids, home IV antibiotics, on central line, peak line, Hickman's line, port management at home, as well as PEG, patch tube, nasogastric, nasojejunostomy tube management at home, SPC, IDC management at home. We're also providing level 2 and level 3 NDI support coordination. And we are also providing TAC and WorkSafe case management. And we're obviously providing consulting and advocacy for families in intensive care. So let's look at the ventilator weaning crisis in ICUs and in hospitals. Let's start with the reality. Ventilation weaning is one of the longest, most frustrating, and also most expensive processes in intensive care. So why does ventilator weaning take so long? The statistics are sobering. 40% of ICU time is spent on weaning from mechanical ventilation. Some patients remain ventilated for weeks, months, even years. And that includes, again, ventilation with tracheostomy, but it can also include ventilation such as BiPAP, CPAP with a mask, or non-invasive ventilation. And because we have clients at home for intensive care at home that are on non-invasive ventilation, intermittently or 24 hours a day or close to 24 hours a day, needing a critical care nurse 24 hours a day so they don't go back to ICU. The longer someone is on a ventilator, the harder it becomes to wean. So, but why does it take so long? Let me break down the 5 critical factors that slow down ventilation weaning in ICU or in hospitals. Number 1, muscle weakness, also known as ICU acquired weakness. Ventilation muscles atrophy rapidly, up to 30% in the first week. Diaphragm dysfunction is catastrophic for weaning. Hospital protocols often don't prioritize aggressive rehabilitation, and a good ICU will actually prioritize ventilation weaning, rehabilitation, mobilization, everything that goes hand in hand with that. Number 2, sedation and opiate practices. Oversedation and overuse of opiates delays weaning significantly. Even appropriate sedation can suppress respiratory drive. Weaning, sedation, and opiates is a delicate balance between maintaining compliance of the patient and simultaneously trying to wean them off the ventilator. Number 3, underlying medical conditions such as chronic lung disease, such as COPD, pulmonary fibrosis, and many others. Heart failure affecting lung function. Neuromuscular conditions such as MND, motor neuron disease, GBS, Guillain-Barré syndrome, myasthenia gravis, just to name a few. And of course, multi-organ dysfunction. Number 4, hospital-acquired complications such as ventilator-associated pneumonia, also known as VAP, fluid overload, delirium and ICU psychosis, secondary hospital-acquired infections. And number 5, conservative weaning protocols or strategies. Hospitals often take a slow and steady approach, fear of extubation failure, limited ventilator weaning expertise on general wards, resource constraints and staffing ratios, and too many junior ICU staff, whether that's doctors or nurses. It takes many years of studying, training, and hands-on experience to become competent in intensive care, whether that's medicine or nursing. So, has your loved one been stuck on a ventilator for weeks? Comment in the comment section. I want to hear your experience. Is that why you're watching this? Let's look at tracheostomy and weaning. When does the tracheostomy enter the picture? If someone has been intubated with a breathing tube down their throat for 10 to 14 days or longer, ICU teams typically should recommend a tracheostomy. If they're recommending end-of-life care, your alarm bells should be going off and you should be immediately reaching out to us at intensivecarehotline.com for advocacy, because that could be a death sentence for your loved one. Because a tracheostomy changes everything. It's more comfortable than an endotracheal tube or a breathing tube. It's easier to manage secretions. It can allow for speech with a speaking valve if weaned off the ventilator. It facilitates gradual weaning in most cases, not in all cases. In some cases, it can also be a lifelong thing, for example, C1, C2 spinal injury, often for cerebral palsy and so forth. And it reduces or eliminates sedation and opiate requirements. But also, it facilitates mobilization and rehabilitation. Not impossible with a breathing tube in the mouth, but much easier to do for a patient with a tracheostomy. But here's what families in intensive care also need to know. A tracheostomy does not mean your loved one will be on the ventilator forever. It's actually a tool that can accelerate weaning when used correctly for the right patients. Like I said, there are some clients, and it's more like our intensive care at home clients. Most of them, unfortunately, need a tracheostomy for the rest of their lives, right? So, but we will be making the distinction today, when it's for the rest of someone's life or whether it's temporary. So let's now look at the hospital tracheostomy weaning process. Traditional hospital approach is start with full ventilator support 24/7, gradually reduce ventilation support. For example, you're going from SIMV ventilation mode, which means the ventilator is delivering a steady rate, 12, 15, 20 breaths per minute, consistently delivered by the machine. You wean that down to 10, 5, and then the patient can take their own breaths. And then you take away the breaths completely from a mandatory delivery mode so that the patient can trigger their own single breath, right? And that's when you gradually reduce the pressure support. And once the patient can tolerate reducing the pressure support and begin tracheostomy collar trials, breathing without ventilation, extend time off the ventilator incrementally, monitor for fatigue, oxygen levels, respiratory rate. This is the traditional approach. And you would have noticed that I didn't mention mobilization rehabilitation, because that is often where hospitals are falling down, where ICUs are falling down. They're not pushing rehabilitation mobilization. In a good ICU, that is part of the ICU skill set, right? And that is when this can happen easily. What's the problem? It can take months or weeks in a hospital setting because of limited physiotherapy sessions, maybe 1 to 2 times daily, interruptions for tests, procedures, diagnostics, ward rounds, infections and setbacks, lack of intensive rehabilitation focus. Patient becomes institutionalized, deconditioned, and often depressed and also hopeless. So, does anyone watching this have a loved one with a tracheostomy in ICU? What's been your biggest challenge? Let me know in the comments. And you would have also noticed by now that I haven't mentioned ventilation weaning with a breathing tube. I've covered that in other presentations, right? If ventilation with a breathing tube is succeeding, right, your loved one should be out of ICU reasonably quickly. They might go on BiPAP or CPAP temporarily, but that's the exception rather than the rule. You know, once the patient is extubated, most of the time they move on to a hospital ward within a few days, sometimes a little bit longer, but you know, that should be the gold standard. So I'll leave that out for today because, you know, just as a side note, your ICU team should always be pushing for extubation and avoiding the tracheostomy, but they certainly should not be pushing for a one-way extubation, because that could be a death sentence for your loved one. You know, if they are potentially pushing for a one-way extubation and palliative care, that's when you, again, should be advocating for a tracheostomy. And that's when you should be reaching out to us here at intensivecarehotline.com so we can help you with those situations, making sure your loved one always gets best care and treatment. So, why does weaning stall in hospitals? The vicious cycle of hospital and ICU ventilator dependency. Let me share what I see happen over and over again in ICU. Patient is critically ill. Ventilation is life-saving. That's week 1, week 2. Week 3 to 4, tracheostomy is placed, weaning attempts begin. Week 5 to 8, slow progress, some trach collar time. Week 9 to 16, patient plateaus, no longer progressing. Family is told this might be permanent or discharge, or no discharge is possible while your loved one is ventilator dependent. So what's really happening? The ICU environment itself becomes the obstacle. Physical deconditioning, lying in bed 20 plus hours a day, minimal meaningful activity, muscle wasting continuous, respiratory muscles don't rebuild strength, huge psychological factors such as anxiety around breathing dependency, or around that they can't breathe independently, depression from prolonged hospitalization, loss of motivation and hope, institutional learned helplessness, lack of day and night rhythm, lack of sleep, lack of healthy sleep, no natural daylight, no fresh air, right? Constant noise. It is a terrible situation. Also, there are systemic ICU limitations, right? Like I said in the beginning, a lot of junior staff in ICU, whether that's doctors or nurses, they are still learning. They don't know what they're doing, and mentoring can be limited. Very high staff turnover in ICU, in most ICUs anyway. If There's not a high staff turnover. That is usually a good sign, but if there's a high staff turnover, that's usually not a good sign, and it means that the ICU doesn't really look after their staff, and that also means patients are not as well looked after as in ICUs where there is minimal staff turnover. Next, physiotherapy sessions are brief and infrequent. Focus is on medical stability, not aggressive rehabilitation. And there is on the one hand pressure to get the patient out, right, as quickly as possible. But there's also, on the other hand, pressure to wean them for as long as it takes, and that takes often too long. Let's also look about the hidden truth about ventilation weaning. Here's what most families don't realize. The hospital's goal and your goal are probably not aligned. The hospital's primary objective is medical stability and safe discharge. Your goal is getting your loved one off the ventilator and back to a meaningful life as quickly as possible. This misalignment is where families sometimes get stuck for months on end. With IntensiveCareHotline.com, we help families navigate this exact situation, creating customized weaning plans and advocating for aggressive rehabilitation approaches. And let's now look at what we offer with IntensiveCareHotline.com, because here we offer ICU advocacy, family support, ICU ventilation weaning consultation. And here's how we help families break through weaning barriers. If you're watching this and you're feeling frustrated, stuck, hopeless, you're not alone. And more importantly, there are solutions. What we do at IntensiveCareHotline.com, we review medical records. We analyze your loved one's entire ICU journey, identify missed opportunities in the weaning process, spot complications that may be preventable. We do daily ICU advocacy. We attend ward rounds virtually or in person, depending on location, or over the phone. Ask the critical questions you don't know to even ask. Challenge conservative approaches when appropriate. Push for more aggressive weaning trials, clearly by looking at medical records and looking at comparable cases that we've seen. Number 3, customized weaning plans are also very important. Evidence-based protocols tailored to your loved one. Collaboration with the ICU team, clear milestones and timelines, alternative approaches when standard protocols fail. Number 4, discharge planning. Explore all options, not just staying in ICU long term, or sometimes ICU may inappropriately suggest that patients can go to nursing home with a tracheostomy or a ventilator. That's just not true. No nursing home can safely look after a ventilator with a tracheostomy. We also then do home ventilation assessments with intensive care at home, coordinate multidisciplinary teams, navigate funding and insurance. So just in the last couple of months, we have started to work with a family whose father had been ventilated for 11 weeks. Hospital said permanent ventilator dependency within 6 weeks of our interventions. He was weaned off daytime ventilation, and and now he's being weaned off nighttime ventilation. And we are very positive that with our guidance that we can help this family get their loved one off the ventilator in due course. And even if they can't, again, that's when we can help with intensive care at home. And this is what's possible when you have expert ICU advocacy. IntensiveCareHotline.com is our website. Go and book your free consultation. We serve families worldwide with support 24/7. If you're struggling with ventilation weaning in a hospital right now, let me know and drop help in the comments, and I'll share more information if you ask your question here. Let's now look at the best solution, I believe. Obviously, if your loved one can't come off the ventilator, right, is transition to home ventilation with intensive care at home. So here is the game-changing option that most families in intensive care don't know exist. Now we're really going to shift gears and talk about something that I believe is on the one hand revolutionary, but has also been around for over 25 years now. and it's transforming lives, which is intensive care at home and evidence-based home mechanical ventilation. Here's the reality. Many patients who are told they need long-term ICU or permanent ICU placement, or they need end-of-life care because there's no perceived alternatives, can actually be safely managed at home with proper support with intensive care at home. And why don't all hospitals tell you about it? They're not set up for home ventilation discharge. It requires specialized coordination. They may not be aware of current evidence-based guidelines, and sometimes they think there's insurance and funding complexities, and sometimes they just want to keep the funding all to themselves as well, or want to control the narrative, who lives and who dies, right? That's all part of it. And sometimes hospitals are completely unaware of it. And also from an ICU perspective, think about that for a moment. ICU can be very black and white. In their mind, there's two options in ICU. One is your family member is getting better and they leave ICU. And the other option is, and they, go to a hospital floor or go to a hospital ward. And the other option is they die. That's very black and white. We have created a third option, which is intensive care at home. We don't see the word black and white, where others see despair and hopelessness. We see hope, and we create hope, and we create opportunities here with intensive care at home. Because the evidence is clear with intensive care at home, and I'm going to show you exactly what the research and our case studies say. So let's introduce intensive care at home and evidence-based home care with home mechanical ventilation guidelines. The guidelines I'm about to share come directly from our website at intensivecareathome.com. You can check out the mechanical home ventilation guidelines. These are the evidence-based gold standard protocols used internationally, right? And I first worked with those mechanical home ventilation guidelines over 25 years ago in Germany when I was part of a pioneering service for intensive care at home there. And then as I moved on in my career, I set up intensive care at home in Australia in 2012, right? And we have been practicing the mechanical home ventilation guidelines from day one. We have also been the only third-party accredited intensive care at home nursing provider in Australia since 2012. So nobody else has the intellectual property, the policies, the procedures, the team, the staff than we have, right, to deliver evidence-based and safe nursing care at home for long-term ventilation, tracheostomy, TPN, and so forth. So who can receive intensive care at home and who can receive this under the evidence-based mechanical home ventilation guidelines? Adults and children with tracheostomy requiring full or part-time ventilation, children and adults with complex respiratory needs, patients with neuromuscular diseases such as motor neuron disease, muscular dystrophy, SMA, spinal muscular atrophy, Guillain-Barré syndrome, COPD patients requiring long-term ventilation support, spinal cord injury patients, patients with Rett syndrome, post-COVID respiratory failure patients, cerebral palsy patients, and the list goes, stroke patients, acquired brain injury patients, and the list goes on. I've just named a few here. The research and our case studies clearly shows home ventilation patients have much better quality of life compared to ICU care. Lower infection rates because there are no hospital-acquired infections. Improved psychological outcomes. Greater functional independence, enhanced family relationships, significant cost savings for healthcare systems. We are talking about saving 50% of the cost of an intensive care bed. So here in the next few minutes, I'm going to show you exactly how home ventilation works, the evidence behind it, and the incredible quality of life our clients achieve at intensive care at home. And once again, you can check out intensivecareathome.com for more information after this call. Now, let me ask you this for those who are here live or for those who are watching this on replay. Did you know that home ventilation with intensive care at home was even possible? Yes or no? I'd be very curious to hear. Now, let's look at the evidence, science, and practice behind intensive care at home and home ventilation. What does the evidence say? Let me walk you through the mechanical home ventilation guidelines that we have published on our website that are evidence-based, and it governs our practice at intensivecarehome.com. Those evidence-based mechanical home ventilation guidelines are not experimental. These are evidence-based, internationally recognized, and also obviously recognized in Germany and Australia standards. Key research findings: safety outcomes. Home mechanical ventilation is as safe or safer than institutional care. Lower rates of respiratory infections, reduced emergency hospitalizations with proper support, comparable or improved survival rates, quality of life measures, dramatically higher satisfaction scores, better mental health outcomes for patients and for families, improved sleep quality, greater sense of autonomy and dignity, functional outcomes. Patients achieve higher levels of independence, better rehabilitation outcomes, maintained or improved muscle strength, higher rates of partial or complete weaning. And of course, there's the family impact: reduced caregiver burden with professional support, improved family relations and family dynamics. Children develop normally in a home care environment. Parents can maintain work and social roles, but even some of our clients can go back to school, work, etc. And also for someone watching here that's working in an intensive care unit or as a hospital executive or a hospital administrator, we are freeing up your ICU bed who's in high demand, and we're cutting the cost of an ICU bed by 50%. Now, Lisandro, I'm seeing your question here, and I'm coming to that once I've gone through my points here. I'll come to that. The clinical requirements for home ventilation: medical stability criteria, stable ventilator settings for at least 2 weeks, no active infections requiring IV antibiotics, but even that can carry on at home. We are giving IV antibiotics at home, adequate oxygenation on a portable ventilator, but we also supply, obviously, oxygen concentrators, oxygen cylinders, manageable secretions with or without suction, and the home environment requirements are adequate space for equipment and care, reliable electricity, backup generators if needed, family commitment to make that happen at home, but you don't need to be involved in the care because we're providing the 24/7 intensive care nursing, safe access for emergency services, support team essentials, 24-hour intensive care trained nursing, which is what we provide. As a matter of fact, we have an amazing team and we employ hundreds of years of intensive care nursing experience combined in the community. No other provider has got the level of expertise, experience, and skills and intellectual property that we have built at Intensive Care at Home over 14 years this year. We have ICU consultant oversight, respiratory physician oversight if needed, allied health coordination, physio, OT, speech, dietitians, and so forth. The difference with intensivecareathome.com is we don't just provide nursing hours, we provide comprehensive ICU level care in your home following accredited and evidence-based guidelines precisely. Like I said, in 2026, I am not aware of any other provider in Australia having achieved third-party accreditation for intensive care at home nursing that has the infrastructure, the team, the knowledge, the intellectual property that we have here at intensivecareathome.com. Now, let's look at the exact model with intensive care at home, how intensive care at home actually works. Let me show you what transformational intensive home care looks like. Again, our service model is reliant on ICU trained nurses 24/7, not agency nurses, not general registered nurses. We have a dedicated team of 24-hour intensive care nurses. Like I said, we're employing hundreds of years of intensive care nursing experience combined in the community. It's unmatched by any other provider. We are specialized in tracheostomy and ventilation management, continuous presence 24/7, same nurses working with the same clients to develop relationships with patients and families so that you can have continuity of care with the people you know, like, and trust. Also, it is an inclusive and comprehensive care model which includes ventilation management and weaning protocols, tracheostomy care and tube changes, circuit changes, airway clearance and secretion management, medication administration, wound care and skin integrity, mobility and positioning, nutritional support via feeding tubes, whether it's a nasogastric feeding tube, a nasojejunostomy feeding tube, whether it's PEG or PEG, or whether it's oral intake, vital sign monitoring, emergency response capability, multidisciplinary team coordination, ICU consultants, respiratory therapists, GP, respiratory physicians, of course, occupational therapists, speech pathology, dietitian, specialist physicians, equipment suppliers. We have the whole network and flywheel. Also, advanced rehabilitation. This is really where home care excels over hospitals. In hospitals, maybe 30 minutes of physio per day. At home with our team, multiple hours of meaningful activity, therapy, community access. Community access. Let me illustrate that. ICU is struggling getting your loved one out of bed, right? ICU is struggling getting your loved one out of bed. Whereas we provide community access. Our clients go out every day, right? Our clients go out every day. And that's where intensive care at home really excels over hospitals, right? It's much more meaningful. Hospitals talk about meaningful recovery, meaningful life. Well, go home and you will have a meaningful life. Real world examples, we're currently supporting a 9-year-old girl with spinal muscular atrophy with overnight ventilation, but also daytime cover, BiPAP overnight, BiPAP during the day, intermittently, cough assist, PEG, tube management. And this girl attends school, has been attending school for many years with our nurses. And this would be absolutely impossible in a hospital ICU setting. It can only happen at home. And our patients and families experience a huge quality of life difference compared to a hospital, normal daily routines, meals together, bedtime stories, family movie nights, etc. Community access, shopping, restaurants, movies, parks, beaches, holidays, and the list goes on. Social connections, visit friends, birthday parties, community events, educational opportunities, children attend school, adults pursue hobbies, work capabilities, some patients return to modified work, travel, holidays, visiting family, life beyond four walls. This is what I mean by living versus existing, because that's what patients in ICU do that are there long term. They're just existing, or they're barely existing. So basically in ICU, in a hospital, it's existing within institutional constraints and limitations. Intensive care at home is living a meaningful, connected life. And again, from a hospital perspective, we are freeing up your most sought after bed in the hospital, which is the ICU bed. And we're cutting the cost of the ICU bed by around 50%. Now, let's look at next, community access and quality of life. Real stories, community access for our clients. Let me share what community access actually means for our ventilated clients. Children with tracheostomy and ventilation, again, can go, to school, preschool, goes to swimming therapy, regular play dates with neighborhood children, family beach holidays, celebrated birthday at local play center or at home. Right? Compare that to hospital. This child would be confined to a pediatric ward, missing critical developmental milestones, social interaction, and childhood joy. Adults with long-term ventilation. Let's look at some M&D clients in particular. We have some M&D clients that are 24-hour ventilated with tracheostomy. Clients live at home with their spouses and adult children or younger children. daily outings in customized wheelchairs, attends, children's sporting events, regular outings with families and friends, and going on holidays as well, right? One of our clients is going on a short holiday next week with M&D. That client is on a BiPAP, but is heavily BiPAP dependent, but we will still go on a short 4-day holiday with them. And our staff are amazing making that happen for them. Compare this to ICU care, or worse, end-of-life care. A lot of ICUs are saying, well, those patients wouldn't have any quality of life or meaningful life. What a whole lot of nonsense, right? Those clients would be in ICU beds with minimal or no outing, separated from family life, missing precious moments in their progressive condition. Let's also look at some teenagers or young adults. As a case study, we have a young client in his early 20s, a high spinal cord injury, ventilator dependent from a C1 high spinal injury, completed their year of high school on a ventilator, right? And is going out regularly with friends, families, attends music festivals with our nursing team, goes to the movies, and is maintaining a great social life. That also leads me to the equipment that makes this possible: portable ventilators with battery backup, mobile suction units, emergency equipment in a rucksack or in an emergency bag that we have with us 24/7, customized wheelchairs, of course, with ventilation mounts, communication devices, backup supplies for outings. Our nursing team is obviously intensive care trained and is also trained to manage all equipment in community settings, facilitate social inclusion, advocate in public spaces, enable participation in life, response to emergencies anywhere if needed, but more importantly, prevents emergencies to begin with. This is why our clients and families choose intensivecareathome.com. We don't just keep people alive, we help them live. Let's now look at weaning successes at home. Why weaning often succeeds better at home. Here's something that surprises many doctors, nurses in ICU. Ventilation weaning can actually progress faster at home than in hospital. Why does this happen? It can happen because there's a better focus on intensive rehabilitation, multiple physiotherapy sessions daily, functional activities, not just exercises, motivation from being in a home environment, being around family, participation in meaningful daily tasks, and participation in meaningful daily relationships with family members. Then there's the psychological factors: reduced anxiety in familiar surroundings, family presence and encouragement, normal sleep-wake cycles, sense of purpose and autonomy, optimal physical conditioning, better nutrition, home cooking preferences, reduced infection exposure, active daily living participation, natural movement throughout the day. And also at home, there can be more aggressive weaning protocols because our nurses can implement intensive weaning trials, immediate response to setbacks, continuous monitoring allows pushing boundaries safely, no competing hospital priorities. So what do home weaning protocols look like? Of course, number one would be a baseline assessment, current ventilator requirements, respiratory muscle strength testing, secretion management capability, psychological readiness, gradual reduction, systematic decrease in pressure support, and ventilator support. Again, going from an SIMV mode, for example, or from an ACV mode to a pressure support ventilation mode, extended periods off the ventilator if possible, building respiratory muscle endurance, monitoring fatigue and gas exchange. And then obviously, ideally going from daytime ventilation to the trach collar, only onto nighttime ventilation. And once that can be achieved, ideally, wean the ventilator daytime and nighttime, and physical activity during breathing trials is also important. And sleep studies can help to assess nighttime needs and cough effectiveness training. So when is weaning completed? Extended independence from ventilation, possible tracheostomy decannulation, tracheostomy removal, ongoing respiratory support as needed, maintenance exercise programs. The success stories we've had here is by predominantly weaning actually children off the ventilator. We had 2 success stories from children who were born prematurely, who had lung disease amongst many other diseases, but it was mainly the lung disease that kept them on a ventilator initially and a tracheostomy. We took them home on a ventilator with a tracheostomy, and we weaned them off from ventilation down to tracheostomy breathing. Once they were fully off the ventilator, eventually they had a lung reconstruction that enabled them to have the tracheostomy removed. And that was done in a home care environment. Obviously, for the lung reconstruction, they had to go to hospital. But the bottom line is they were able to be weaned off the ventilator and the tracheostomy at home. And that took about 6 months in total. So you can see nothing is impossible here. These transformations happened at home with intensive care at home, not in a hospital. So let me share some questions that we get most frequently, but let's first look at Lisandra's question, who says, hi, what about patients with an anoxic brain injury with tracheostomy and PEG tube, not talking, no mobility, eyes impaired, and can only hear us, little responses to command? Lisandra, I think this is actually even more important that your family member goes home, right? Well, it sounds to me like the hospital environment is keeping your family member hostage to your family member being confined to a bed. I'd imagine what that looked like at home with the examples that I talked about so far. Right? Imagine you're going home, a family member gets out of bed every day, has family members around them, right? Things can only go up from there. Right? I've seen it many times. Right? So don't let your family member's current circumstances, I don't know who that is it mom, is it dad, is it spouse, is it sibling, child, I don't know. Don't let the current circumstances hold you back of what's possible, because that's what I'm hearing here, that the current circumstances makes you think that it can't be changed. Well, nothing could be further from the truth. It can be changed, but you need to take the first steps. So other questions that we get quite frequently, is intensive care at home really safe? Answer, yes, when provided with third-party accreditation services like we are at Intensive Care at Home, and provided obviously by intensive care trained nurses 24 hours a day, because our nurses are ICU trained and ventilator competent. 24/7 intensive care nursing presence means immediate response to issues, prevention of issues, emergency protocols and equipment always available, lower infection risk than hospital environment. As a matter of fact, much lower infection risk than in hospital environment. Evidence shows comparable or much better safety outcomes. Concern number 2, what if there's an emergency? We're prepared for every scenario. Our nurses manage emergencies almost daily. However, they're also preventing emergencies daily. Direct communication with the medical team. Hospital has full care plans on file. Equipment redundancy, i.e. backup everything. And that's how we work with those emergency situations. But like I said, one of the questions that we have in our interviews for our ICU nurses is, what do you need to do today to prevent an emergency tomorrow? To prevent a hospital readmission tomorrow? That is a much better question to ask. Okay, so Then the next question that we get from families, of course, quite frequently is, how much does it cost? Now, how much does it cost? It costs about 50% of an ICU bed. So ICU beds cost between $5,000 to $10,000 per bed day, depending on location and condition. Intensive care at home costs around 50% of that, also probably slightly dependent on location. In Australia, many clients are NDIS funded, but also TAC funded, for example, DVA, but also there can be private health insurance coverage. Self-funding options, of course, but the bottom line is whoever's going to pay for it, it is far less expensive than ICU hospital care. We also have dedicated NDIS specialist support coordinators who can help you. We have a TAC and WorkSafe case manager, but we also obviously have insights into the funding side of things. Otherwise, we wouldn't exist. Go to intensivecareathome.com and contact us for a funding and clinical assessment, and we can guide you there very quickly. Other questions we get is, will insurance or NDIS, for example, cover this? There are many funding pathways that exist. NDIS allows for a strong coverage for children and adults under the age of 65. Obviously, if they're on the NDIS or if they can get on the NDIS because they have actually a disability. There's also government programs such as Departments of Health state-based support. There can also be some hybrid funding models. We navigate this complex landscape for you and can guide you. Next question and next concern that we get from families, what about the family burden at home? Well, we reduce family burden, not increase it. Professional 24-hour intensive care at home means families can rest. Families can return to work. Siblings get attention and normal childhood. Spouses can maintain relationships. No more nights of disrupted sleep. No more nights staying in ICU. No more days going into ICU. Families become families again, not caregivers. Next concern that we hear every so often is, our doctors say it's not possible. Well, education and evidence changes minds. Many ICU consultants are not aware of current capabilities. They haven't read our website. They haven't read our case studies. We collaborate, of course, with medical teams. We provide evidence-based protocols. We have hundreds of years of intensive care nursing experience combined on our team. We offer trial periods to demonstrate safety. We connect with progressive physicians nationally. And also we, sometimes, not all the time, we can provide training in the hospital. So, before we take someone home, we do a few training shifts in hospital so that the discharge is running smoothly. We've successfully transitioned patients from ICU across Australia despite initial physician resistance by demonstrating our evidence, safety, and of course our track record since 2012. So, what to do next? From here, how to get started, your roadmap to home ventilation, including home ventilation weaning. Whether your loved one is currently in ICU, on a hospital ward, or in a facility, there are pathways home. Reach out to us here at intensivecarehotline.com or intensivecareathome.com. Book a consultation call with me. We review medical records, assess your current situation, identify barriers to progress, create a customized action plan. For home ventilation and intensive care at home assessments, again, go to intensivecareathome.com, book a consultation call with me. Me and my clinical team can review cases. We're looking at funding pathways, home environment assessments, comprehensive care plan developments. We coordinate medical teams. We connect with treating doctors, coordinate with hospital discharge planning, arrange equipment and supplies, recruit and train our nursing team, of course, and we help you, or we get you involved in staff selection if you want that, making sure we find the right team for your home care environment. Home transition, gradual transition, hospital to home, initial family adjustment support, of course. 24-hour nursing team is established, and ongoing nursing and medical oversight 24/7. And most importantly, living life, rehabilitation, intensification, community access planning, quality of life optimization, weaning protocols, if and when appropriate, long-term wellness focus for the client and for the family, of course. So, final thoughts, hope and possibility. I want to leave you with this message. Ventilator dependency is not a life sentence to ICU or institutionalized care. Every single day, we're providing that people on ventilation, adults and children, can live rich, meaningful, and connected lives at home, that are attending school, going to work, celebrating milestones, maintaining friendships, being part of their communities, living, not just existing. If you or your family member are in a hospital right now and you're being told you have to stay here long term, there's no hope, the only option is to stop life support, or they're telling you you're permanently ventilator dependent, don't give up hope. I want you to know there are alternatives. The evidence is clear, the technology, the know-how exists, the expertise is available. What's needed is the right team. We're here. Proper coordination. We navigate this. Family commitment. You have that. Evidence-based protocols. We follow these to the T. Where to find us? Again, intensivecarehotline.com if you're in ICU, for ICU consulting and advocacy, daily ICU support, medical record reviews daily, discharge planning and consultation. Or our next step then is intensivecareathome.com, home mechanical ventilation, tracheostomy care, 24/7 ICU nursing at home, rehabilitation services and community access support. So I'm going to wrap this up. Thank you all so much for joining today's live stream. Whether you were here live or you're watching this on replay, subscribe to my YouTube channel for regular updates for families in intensive care or intensive care at home. Click the like button, click the notification bell, comment below what you want to see next. So if you have any questions right now, let me know right now, type them into the chat pad. And otherwise, I will wrap up. Also, let me know what topics you want me to cover. Is this the right content for you? Do you want me to cover any other topics? Keep the questions coming so I can create the content that you want. If there are no other questions, I will wrap this up here now. I want to thank you once again for your time, for your viewership, for your subscription, and spread the word for anyone needing intensive care hotline or intensive care at home. Share the video with people that need to hear today's message. Take care for now. Have a wonderful weekend and a good week ahead. Take care.